Hello, everybody, and welcome to the Student Success Session on Respiratory Failure with Mechanical Ventilation. As always, you know that I talk pretty quickly, and so it's very important that you play pause right so that you can not become overwhelmed and so that the information can really get downloaded in your head. I will tell you that this information is very important. Pretty much all of these concepts that I'm going to talk about on this session or during this session you're going to be tested over at some point in the course. And so please, please, please be sure and do this and take your time and have a good understanding. Now, because students are not always in the clinical setting or not always able to get ventilator exposure, some students will say to me, was there a YouTube video? And there's a lot of them that are out there that can help you with ventilators, but I truly believe they're at a much too detailed focus. And you really don't need to have that much of a detailed focus. You do need to know the basics about ventilators so that you can assess and take care of your patients, but the big details you just don't need to do unless you want to go to respiratory therapy school as well. This is their job, so let's just get through this. All right, so let's do our first scenario. We've got a 20-year-old college student. They were found by their roommate face down in a puddle of vomit and brought to the emergency department. The patient is confused, yelling loudly, uncooperative, and smells strongly of alcohol. Imagine that. Blood pressure is 140/80, heart rate is 122, and the respiratory rate is 14. Supplemental oxygen of 40% by simple face mask is being administered, but the patient keeps pulling off the mask, and so here's your arterial blood gases. And then what treatment do you think is indicated at this time? So let's play along again. Pause the recording, try and configure this ABG first. All right, so when we look at this ABG, we can see that the pH is 7.30. The pH is down. We have the PCO2 that is elevated. Per our acronym ROAM, respiratory is opposite, so we know we have a respiratory acidosis. We look at the bicarbonate, and we see the bicarbonate is okay. The PO2, however, is 68. That is less than 80 to 100, and the O2 sat is low also. So we definitely have a respiratory acidosis with hypoxemia. So what do you think is the treatment? So the answer is intubation and mechanical ventilation. Now, a lot of students will put, well, why can't you deliver O2? The O2 is down. And let me get my little pointer thing. So we know that if you delivered O2, that would certainly help the O2, the low O2 levels that this patient has experienced. But there's two things that are problematic with that. And one is that you've got a patient who has is not tolerating a mask and who keeps taking the mask off. And so therefore, it's not probably going to be very helpful. The other thing about that is, yes, if you give O2 to this patient, and certainly you would, as you're preparing to or have the physician preparing to intubate, you are not going to really do anything about the CO2 because delivering O2 in and of itself, all by itself, is not going to help the CO2 retention. So that problem has to be addressed, and O2 is not going to address it. Now, another option would be to give the continuous positive airway pressure. Again, we'll learn later that CPAP as well as PEEP help with oxygenation. It does not help with CO2 retention. And again, this patient has a bad enough CO2 retention that the pH is markedly abnormal. So we need to deal with that, and really the best method of dealing with that, and also to protect this patient's airway, because we know that he's already vomited. He could vomit again, as individuals who have had a lot of alcohol are prone to do, and therefore we really do need to protect his airway by intubating the patient. A 56-year-old woman is admitted after ingesting an overdose of prescription drugs, and she's unconscious and has inadequate ventilation. After intubation, mechanical ventilation was begun, and the assessment parameters are noted. So identify a likely cause for the vital sign change. So let me point out to you what assessment parameters have changed, and I know that you can figure this out, but we're just going to go through it in the details. We see that the blood pressure was 112/78 prior to the mechanical ventilation, but now we see that it has dropped slightly. It has dropped slightly. It's still within a semi or mostly normal parameter, but this systolic to diastolic number is closer together. In other words, they're closer in their value. We also see that the patient's heart rate has gone from 80 to 110. And then, of course, the respiratory rate is really the same. Intermittent mandatory ventilations just simply means what the ventilator is delivering was 16 breaths, and then what the patient was delivering was 16. You can kind of ignore that. We see that the oxygenation status has greatly improved with the ventilator. So truly, the two vital signs that we are most concerned about is that blood pressure and the heart rate. And what has happened is the addition of positive pressure has reduced the cardiac output. So let's talk about that. What does that mean? Well, all ventilators, all modern day ventilators that are currently in use apply positive pressure. And you don't have to know the mechanics unless you want to. Inquiring minds, email me. But the bottom line is that the way we normally breathe, there is negative intrathoracic pressure. And the ventilator does not breathe or does not wait for the individual to, quote unquote, be ready for a breath. The ventilator just shoves in air whenever it's convenient for the ventilator or whatever the settings have been applied. So that is why all ventilators are considered to be positive pressure ventilators. And positive pressure is against normal physiology. And with positive pressure that's being applied or put in place inside the intrathoracic cavity, that will cause a reduction in cardiac output. How do you know? Because as evidenced by the fact that the heart rate has gone up because the cardiac output has gone down. So you see physically here the signs of compensation. The heart rate goes up, and even though the blood pressure went down slightly, but still kind of in the normalish range, it is that elevation in heart rate that we see. Now, a lot of individuals and nurses, seasoned nurses, may think, well, that heart rate's going to go up because you're shoving air in this individual's chest, and so it's not just the most comfortable feeling in the world. And so this, of course, can cause anxiety for the patient, but that is not what's going on. This patient, you always have to consider that the application of a ventilator, again, note this statement here, this is the most important, the application of a ventilator or the application of PEEP, which we'll talk about in details later, will or can result. Doesn't always, but it can result in the same complication, and that is decreased venous return. So that's venous return or venous blood that comes back to the heart, and that will cause a decrease in the cardiac output. Very, very important that you understand that positive pressure being applied outside, in other words, by mechanical ventilation, can cause decreased venous return and decreased cardiac output. Super important. All right, so let's look at a ventilator screen. And this is probably my favorite model of a ventilator. This is kind of like the Volkswagen, the cheap version of a ventilator. There are some fancy Cadillac modules, but all of them do have the same components or the same things that individuals can do to use them. The biggest key is for you to figure out where that is, and you will as you look at different ventilators. So let's look at this ventilator, and we can see that with each breath, you can see the waveform that's on the screen. So a waveform will appear. What I do want to show you is little bits at a time, and so we're going to first talk about the mode. So there are approximately 30 modes, ventilator modes, and you really don't have to know a lot of them, just a few of them. CMV is referred to in the course as complete mandatory ventilation. And let me back up by saying that, well, what the heck is a mode to begin with? Well, the mode, all it is how does the ventilator respond or work with the patient? Does the ventilator deliver all the or do all the work, or is the patient doing all the work? It's kind of like, what's the difference between an automatic transmission versus a manual transmission? Manual transmission, you do most of the work, the driver does most of the work. Automatic transmission, the driver does the least work. So that's the same with modes. So there are certain modes that do more work, such as complete mandatory ventilation. The patient can't do any work. Rarely ever see that in the hospital, though it is delivered in this course. Assist control ventilation is the next most amount of work that is done by the ventilator. And then there's SIMV, and then there's spontaneous. SIMV is kind of a cross between some ventilator work, some patient work, and then spontaneous means the ventilator's just there for looks and a little bit of support. The patient's doing most of the work. That's what you need to know. Which modes are delivering the most amount of work, and the ones that I gave you are the ones that you're tested on. Dr. Reed may give you some more information on modes, and then, of course, if you do an article, there's even more. So these are the main things that you need to know. Mode, how does the ventilator and the patient connect? Modes are determined where the ventilator does most of the work, the patient does most of the work, one or the other. All right, now we look at this next setting, and we know that for every breath that you take or the ventilator delivers, there has to be a tidal volume. In other words, the amount of air that is going into the lungs. And think of your lungs like a balloon. So it's like if you had a party balloon, you blew a little bit of air, the lungs would, or the party balloon would inflate just slightly, but if you blew more air, they would inflate a whole lot. Now, there are different ways to deliver tidal volume. And in our course, we really address pressure control, which is a way to deliver tidal volume, or this next one, which is volume control. So these are just two different ways that the tidal volume can be delivered. And again, it's indicated on the ventilator screen of which manner the patient is getting pressure control, or their tidal volume versus pressure, or their tidal volume versus just volume. Now, in your notes, I did review the differences between the two. It is very rare that Dr. Reed would ask which is which, and it is definitely inappropriate for the nurse to decide which is which as far as prescribing a ventilator volume delivery system. The physician is going to be the one that is going to determine whether the patient should get volume delivered by just volume control, or the patient should get volume delivered or tidal volume delivered by pressure controlled. You just need to know that there are a couple of different options for the tidal volume to be delivered to a patient. A 56-year-old woman is admitted after ingesting an overdosage of prescription medication. She's unconscious. She has inadequate spontaneous ventilation. So after intubation, ventilation was begun, and here we go. You can see that this has all of the components, and we'll talk about that in a second, but I'm going to ask you which of the following intervention would not be appropriate. So again, we look at what has been addressed or what has been prescribed by the physician. It's an assist control. We have 12 breaths per minute. There is 0.4 is the same as 40% supplemental oxygen, and the tidal volume delivery is 500. And there's your blood gases, and you can see that the patient is still or has a respiratory acidosis, and that the patient is hypoxemic. So we still have the two major problems that can occur with respiratory failure, and that is an inability to maintain a normal pH, an elevated CO2, and an appropriate oxygen level in the blood. So which of the following interventions would not be appropriate? So all three of these interventions, the increase of PEEP, the increase of O2 delivery, and the increase of a rate by the ventilator, are totally appropriate. The only thing that is not appropriate is answer D, and that is change the mode to synchronized intermittent mandatory ventilation. Because synchronized intermittent mandatory ventilation means that this patient is going to do some of the work. And because the scenario has read that this patient can't do the work because they have inadequate where's my red? Inadequate spontaneous ventilation, this patient is not able to help with their own ventilation. This patient needs lots of support. And that's what assist control does. That is the mode that offers a lot of support. Now, a lot of students will look at this and answer it wrong, not because they didn't know that SIMV would be totally inappropriate, but again, this is a negatively stated question. You were asked what is not appropriate instead of what is appropriate, and again, Dr. Reed will do this to you too. Hopefully, if you miss this, you'll never miss reading it the wrong way, of answering it the wrong way again when the points don't count in these practice questions. Remember that not means what would you not want, and we would not want the patient to have to be responsible for breathing. They're not able to. Now, when we talk about the ventilator itself, there are several other things that are on the ventilator, several other settings. We've already talked about volume, and you can see that volume and the rate are on this side of the ventilator. So I always draw like an imaginary line here, and so I say, okay, on this side of the ventilator is the volume amount and the respiratory rate, and that is the respiratory rate that is delivered by the ventilator. And these two things, the volume amount and the respiratory rate, control CO2. So on this side of the screen, and I don't know why it has these weird lines, but you'll just have to kind of deal with it. These two things, the volume and the respiratory rate, control the CO2. And we have talked about this, and this is just a reminder to remember that CO2 is controlled by the volume, the tidal volume, so that's the depth of a breath, and the respiratory rate, whereas O2 is controlled by the PEEP, positive end expiratory pressure, and the amount of supplemental oxygen. Now on this ventilator you can see that supplemental oxygen is being delivered at 21%. Now it could be, it's also known as FiO2 as a fraction of inspired O2. That's the same thing as saying extra O2. So if I were to ask you, well, what are you breathing right now? You would know that the legal drinking age is 21, and that's what room air consists of, 21% O2. And on a ventilator, we can set it at room air if the patient doesn't need extra air. But let's say the patient is profoundly hypoxemic, well, then this number is going to have to go up. And I know that in your J1 semester or even J2 semester, you were taught that, we don't deliver extra oxygen. Well, you do. Extra oxygen has to be delivered when the patient is hypoxemic. But the rule is you deliver the least amount of O2 when at a time, as long as the patient needs it. So again, if the patient doesn't need supplemental oxygen, then we'll give 21%, such as what you see on this ventilator, as opposed to if the patient was profoundly hypoxemic, it can go up to 100%. But lots of extra O2, anything higher, especially I think Dr. Reed mentions 50%, then that has a detrimental effect. So it's always about risk versus benefit. And if the patient is profoundly hypoxemic, well, the risk of an elevated supplemental O2 is worth it. But if they're not hypoxemic, then the risk is not worth it. So that's what you have to decide. You have to, or the physician has to decide, is the risk versus the benefit. And so that's very important. All right, so let's keep moving on with our questions. We've got a man that's admitted with acute respiratory failure. He's been intubated and is being ventilated mechanically. So there's our ventilator settings, and then we see the ABGs. So which of the following ventilator changes is anticipated? And this scenario is what you can expect on the exam. So let's go through everything. We see what the settings are here, and we're not really going to address them until we look first at the ABG, because we have to find out, well, where is the patient in their ventilator management? And we see first that the pH is 7.30. So we know, this patient has acidosis. And then we look and see that the CO2 is elevated. So if the CO2 is down and the CO2 is up, there is CO2 retention, and the pH is down, that the mnemonic follows. We have respiratory opposite. We have a respiratory acidosis. Then we look at the bicarb, which is totally normal, and we look at the PaO2, which is also normal. Now again, recall that PaO2 normal is 80 to 100, and students always, every semester, they look at this 84 and they think that it's 84%. It's not. It's millimeters of mercury. That is the PaO2, and that is completely normal. So the oxygenation status is okay. What's wrong with the patient is that they are acidotic because of CO2 retention. What do we do to change CO2 or to remove CO2 in this instance? Well, we want to breathe deeper and or faster. So decreasing the IMV rate, the intermittent mandatory ventilation, means that we would want to decrease the 6 breaths to, I don't know, 5? Well, no, we know that's going to just cause more retention of CO2. We definitely don't want to decrease the tidal volume because that also will cause CO2 retention. We don't want to change the FiO2. The oxygenation status on this patient is just perfectly fine. So that leaves the only option is to increase the IMV, intermittent mandatory ventilations. That is the rate of the ventilator. We want to increase that. And so that leads us to a restatement of this rule, one of what I call my Hughes clues. If the problem is with the CO2, change the tidal volume or the respiratory rate on the ventilator settings. If the problem is with oxygen, then change the FiO2 or the PEEP on the ventilator settings. So this is a rule that you need to keep in your head, because this is the kind of question that Dr. Reed will ask. So do you, the nurse, determine what the ventilator rate is? No, but certainly if the physician calls or you call the physician because you are reporting this abnormal ABG, and the physician says, oh, well, why don't you increase the oxygen delivery? You would say, no, the patient has a CO2 problem, and the patient should have the rate or tidal volume. Now, I know that this is not the ABG that you just dealt with, but all I did is make the point. If the change should be made with CO2 problem, then change the tidal volume or the rate. You're going to have to figure whether you should increase or decrease the rate or tidal volume. And then if the problem is with O2, you need to change the O2. And again, it can work either way, either increase or decrease either of those settings. We've got a patient, a woman who's 2 days post-cardiac surgery, and she's on a mechanical ventilator. There's her settings here, which we'll address in a second. But we have to look at the ABGs and then determine what ventilator change should be made. So we look first at the pH, and we see that the pH is normal. It is in the normal range. Now we have to look at the CO2. The CO2 is between 35 and 45, so we see that the CO2 is also normal. Now we look at the PO2, and we see that this patient is profoundly hypoxic. The PO2 is definitely less than 80 to 100, or the PO2 is definitely less than Dr. Reed's lower marker of acceptance, which is less than 60. Bicarbonate at this moment is normal. So we see that we have an oxygenation issue. So what ventilator changes would we make? Well, we see that the rate and the FiO2 is at 60% or 0.6. And so we see that, you know what, this patient is hypoxemic. We know that that is on the table. The tidal volume and the breaths are going to be fine. Why? Because the patient's CO2 is within the normal range, as is the pH. We do not need to change anything with the rate or tidal volume. We see that the delivery of PEEP is at 5 centimeters, and we could increase that. Why? Because what I told you is when there is an O2 problem, the changes should be made to either the O2 delivery, so the supplemental O2 delivery, or the PEEP. So we need to now determine that we can either increase the FiO2 or increase the PEEP. So we have to find the answer that matches that. So increase the tidal volume, we know, that is a no. We know that we don't have to deal with IMV. We don't want to decrease the O2 because this patient's hypoxic. So the only option that is correct is increase the PEEP. Again, problems with O2, change the PEEP or the FiO2. The high pressure alarm on a volume ventilator sounds. So this would be caused by which of the following? Select all that apply. So what does that mean? So again, the alarm is always present. And alarm settings should never be turned off. They can be silenced, but never turned off. And what does it mean when the high pressure alarm fails? So what happens is when a patient is placed on a ventilator, the respiratory therapist will set, per the patient's normal, physiologic normal, because every patient can be different, the respiratory therapy will set what the patient's resistance is inside the lungs. In other words, as the ventilator is blowing in air, just like you blow in air in a party balloon, if the balloon is never been blown up before, you know that you're going to have to put more force behind blowing in air versus a balloon that's very stretchy. Then it's much, much easier to blow in air, and it's the same thing with the lungs. So when the high pressure alarm goes off, that means something has happened that has increased the resistance or decreased the compliance. Resistance means the ability of those lungs to stretch. Compliance means stretchiness, so the compliance will be less. It will be less stretchy when there's more resistance. So the two are kind of opposite terms. More resistant, less stretchy would be very similar or very like problems. So if there is less compliance or less stretchiness or more resistance, then the high pressure alarm is going to sound to let you, the nurse, know that, you know what, it's not easy. It's not as easy for me to blow air in this patient's lung. So what might be the factors? What could the patient or what could be occurring with the patient that would cause that high pressure alarm to go off? And of course, the answers are going to be, if the patient is biting on the tube, well, that's going to create resistance against the flow of air on the ventilator. So the ventilator alarm is going to go off. What about a pneumothorax? Well, yes, if the patient has a pneumothorax, then this is going to cause more resistance, and it's going to cause the ventilator to have to blow harder or use more force to blow in air. Excessive secretions are another cause for resistance. In other words, if there's a lot of snot in the bronchial passageways, well, then that is like a brick wall, and it can be very hard snot or thick mucus. That is like the air or the ventilator hitting a brick wall when it's trying to blow in air. So these three things are what causes increased resistance, and that will cause the high pressure alarm to go off whenever the ventilator is trying to blow in air. Now that's the opposite from what would occur if there was low pressure. So we go back to the options of that we did not select, and one of those was a cuff leak. And so in other words, whenever there's a leak anywhere in the system, whether it's with the endotracheal tube cuff or in the ventilator tubing, such as the ventilator's disconnected, any of these things will cause the low pressure alarm to sound, because the ventilator, as it's pushing in air, expects to meet some resistance. So it's got to have that just right resistance, not too much, not too little, and the respiratory therapist will set what that not too much, not too little is because of patient variation. So that's what these alarms sound. A 70-kilogram patient's on a mechanical ventilator after surgery. Now he's being weaned with SIMV pressure support and 40% oxygen. So which parameters indicate that the patient is ready to be extubated? Because again, we don't want this patient to stay on the ventilator longer. Now, I have underlined pressure support. So that's a new setting on the ventilator. I can never find where my thing is. All right. So That is indicated on this screen by PS. So hopefully your eyes are drawn to that. I'm going to erase everything so that you can see that again. But here it is here, pressure support. It's identified by PS. In our course, it's usually called pressure support ventilation, or PSV. So what does that mean? Well, when we want the patient to come off the ventilator, again, this will vary depending on the patient and the physician prescription. Sometimes we wean them slowly. Sometimes they're weaned fast. So sometimes patients are placed on SIMV, which I had already mentioned to you, that SIMV, as indicated here, SIMV mode is where the patient does a good portion of the work and the ventilator does some of the work. And because we are now demanding that the patient do some of the work, we have increased the work of breathing with an endotracheal tube, which is about the size of a large straw, which is much, much smaller than a nostrils and regular just breathing in room air. And we've also increased the length of tubing and stuff between the patient and the ventilator. So all of these things, the endotracheal tube and the tubing to the ventilator itself, increase the work of breathing for our patient that we want to breathe. So you know what? We're going to give them a little help as we start to wean them off the ventilator, and that help is in the form of pressure support. Now, you don't have to know numbers, but I've given you numbers so that you kind of get a sense of what I'm talking about. So when you have numbers, and again, in the clinical setting, I've seen the highest number as 20. So if I give this patient 20 of pressure support, which is a setting on the ventilator, then I've given them a lot of support. So as the patient inhales, the ventilator will go, whew. So the ventilator will help push that breath. So it's not that the ventilator is doing all the work. The patient started or initiated the breath in, and then the ventilator just gave a little push. If the setting was down at 2, then that means the ventilator is not giving them much of a push. The ventilator is just kind of barely touching them or pushing. Whereas if it's 20, then the ventilator is giving a fairly large push. So again, the patient's doing the work of breathing. The patient's inhaling, but it's just that the ventilator is doing some assistance to kind of help that patient overcome the resistance that's in a ventilator circuit and endotracheal tube. So we go back to our question, and we see that the patient is being weaned off SIMV. And pressure support's in place, and 40% O2. So again, pressure support is help on inspiration. Pressure support is help on inspiration or inhalation. And now to the question, which parameters would indicate that the patient's ready to be extubated? So there's a whole lot of very specific parameters here. I bet you can figure it out. I bet you can figure it out. And what is the answer? Well, the answer is A, because A says that, number one, the patient is inhaling a fairly large tidal volume, 500. They have a really good respiratory rate. Now, know that usually on a ventilator, patients' respiratory rate is a little rapid or a little bit higher than normal, if normal is between 12 and 20. And it's usually slightly higher because yours would be too if you had a tube shoved down your gullet. And then this patient is strong enough to lift their head off the pillow. Whereas this other two here kind of indicates that the patient is still stressed. 6 is not enough breaths, 34 is way too many breaths, 10 is not enough breaths. So really, answer A is the only answer that really says to you, hey, this patient is doing great. So what are things that you consider as the nurse that indicate to you that your patient is ready to be weaned? And those things are going to be that they're awake and alert, that they can somewhat follow reasonable commands, and that they're not on a lot of sedation, and that they don't have vital signs instability. In other words, if you have your patient on a bunch of medications to support their blood pressure, that patient is unstable. And it's not that their respiratory system's unstable, it's that their whole picture is unstable. So we do look at all of the criteria. Now, I do have here that the tidal volume should be 5 mils per kilogram, and that's for those inquiring minds. That is not something you're going to be tested on or that you need to know. But it's kind of a guideline that physicians will use that say, well, hey, if you can pull a big enough tidal volume, then you're ready to be extubated. A patient is admitted to the ICU with sepsis. During the morning assessment, the nurse notes that the patient is extremely dyspneic, anxious, complaining of tingling around the mouth and fingertips, feeling lightheaded. Blood pressure is 120/82, respiratory rate is 36, and the heart rate's 110. So what intervention is indicated? So let's look at all of these vital signs. And what do they say to you? Well, this patient truly does have a very rapid respiratory rate. But the blood pressure seems to be okay, and the heart rate is 110. So what are the things that I'm trying to relay to you? This patient is anxious. And yes, anxiety can occur just by being in the hospital, but seems like this is somewhat extreme. And when the heart rate is up, and especially the respiratory rate is up, what's going on? Well, I would make you or recall to you that where is the respiratory center? Well, the respiratory center is in the brain. And so whenever there is a rise in CO2 or a drop in O2, the brain is going to go, yo, where is my oxygen here? And if there is a low O2, the brain will tell the lungs to breathe more and breathe faster. And the reason for that is because the brain needs some oxygen, and so therefore the brain is telling the patient to breathe deep. And that's why the answer to this question is assess the non-invasive oxygen saturations. You must know that any patient that is either have CO2 retention or O2 decrease can have mental changes, altered mental status. And why is this patient having tingling around the mouth and fingertips? Well, when the O2 goes down, the brain goes, yo, where's my oxygen? And the brain tells the lungs to breathe fast. And as the lungs breathe fast and deep, then CO2 is going to be removed. And CO2 removal will cause respiratory alkalosis. Respiratory alkalosis sign and symptom is tingling around the mouth and fingertips. And so that's what this scenario is. This scenario is trying to lead you down the path that this patient is sick. They have sepsis, which is an infection, and this patient is sick. So this is a classic signs and symptoms, or the early clinical manifestations, of ARDS. These are the early clinical manifestation of ARDS, Adult Respiratory Distress Syndrome, which is all about O2. So what has happened? We've switched gears. We are now talking about oxygenation issues. We were mostly, in the beginning of this presentation, talking about CO2 or hypercapnic problems. Now we're talking about oxygenation issues, and oxygenation issues is all about ARDS. So we go back to a 20-year-old college student who is in the ICU, and ARDS is suspected, Adult Respiratory Distress Syndrome. And because ARDS is a problem with hypoxemia, the things that are changed are the oxygen, supplemental oxygen delivery, and the PEEP. So let's talk more or find out more about PEEP. So what is PEEP, and which option is not an effective PEEP in this patient? So Let's talk about PEEP. PEEP, first of all, stands for positive end expiratory pressure. So PEEP is all about expiration. It is about keeping our party balloon, which is the alveoli, open. So when you inhale, the balloon inflates, the alveoli inflates, and when you exhale, the party balloon or alveoli balloon deflate. Positive end expiratory pressure means that the pressure stays in the lungs and that it will keep the party balloon or the alveoli from completely collapsing. Now, you and I have PEEP. We have PEEP normally. Again, inquiring minds, email me if you want to know how that happens. But all of us have PEEP, physiologic PEEP or ventilator PEEP, and our normal PEEP is 3 to 5. So you can see that 14 of PEEP is very high. So what does PEEP do? Well, it helps with oxygenation by driving the pressure of oxygen. It increases the pressure of oxygen, and that means that it keeps the alveoli open longer, and so therefore the oxygen can diffuse. It opens collapsed alveoli because it keeps that party balloon or alveoli open, and it decreases the alveolar surface tension so that, again, the alveoli can help with oxygen diffusion. So what doesn't? Again, a trickery. Where's my little mousey thing? There it is. Oh, it is not. The question asks what does not PEEP do, and that is it doesn't increase O2 toxicity. Because here's what happens. If you have a patient that's on very high O2, we know that O2 has the potential to be toxic. Well, we can bring down the supplemental O2 by increasing the PEEP. We can bring down the supplemental O2 by increasing the PEEP because supplemental O2 and PEEP, positive end expiratory pressure, both help with oxygenation. A 20-year-old college student is in the ICU. ARTS confirmed the PEEP is gradually increased to 20 centimeters so that FiO2 can be reduced while maintaining a PO2 greater than 60. And a left pneumothorax has developed because of the high levels of PEEP, and so the ICU nurse is awaiting the arrival of the surgeon for a chest tube insertion, so which assessment finding is an indication of an impending crisis. So, oh my goodness, this is a lot of concepts that are in this question. So let's deal first with the concepts because, again, they are on the exam in some way, shape, or form. So I have circled the fact that, or underlined this, that while maintaining a PO2 of greater than 60. Now, I told you in the beginning of the course that normal is 80 to 100, and that is true. But when you have a patient with ARDS or oxygenation issues, they are very, very sick patients. And sometimes it is very difficult to get the PO2 to 80, and so therefore it is a consideration in this course. I don't know if every physician deems this as true, but Dr. Reed writes the exam, so you better deem it as true, that the PO2 must be at least 60 or better, or the patient is in jeopardy of dying. So that's her kind of lowered normal value that is somewhat accepted. It's not really the best goal to have, but it's an acceptable goal to have when your patient is super, super sick. So that's the first concept. The next concept is a pneumothorax has developed. So what are we talking about with a pneumothorax? And I'm going to skip over to this picture. So when you have a pneumothorax, and one of the things I said was that just means that our party balloon has popped. So the alveoli, one or several of them, have popped because of the high pressure of PEEP. And therefore, as air goes in, air will leak out through the alveoli and collect in the pleural space, and as more and more air collects, then the lung will collapse. And this air can slowly leach out into the subcutaneous space. So that is what is happening here. We know the patient has been told that they have a left pneumothorax, And so when you see this answer, I am sorry that I keep putting the line, but it's hard to see on the screen. When you have this answer, if that was the one you picked because you said, you know what, um, we know that whenever there is a pneumothorax, that the patient will have subcutaneous air because that tells me that there is a pneumothorax when there's diminished breath sounds or subcutaneous air. And so what I say to you is, what were you asked? And you were asked about an impending crisis. So you cannot pick these two things. Why? These do not indicate an impending crisis. These indicate the patient has a pneumothorax. Well, you know the patient has a pneumothorax. It's been identified right here. The physician has made a diagnosis. And so you do not want to report anything that is expected. And if your patient has been diagnosed with a pneumothorax, a left-sided subcutaneous emphysema does not state or not indicate a crisis. It's expected because it goes with the diagnosis. Now, and diminished breath sounds are the same. Now, if your patient didn't have a diagnosis, then would you report those two findings? Well, of course you would, but they have a diagnosis. So what is the one that is about an impending crisis? And that is this answer here. That is the tracheal shift, answer B. Tracheal shift to the right. And let me go back to the picture so I can show you. You see that whenever there is air here in the pleural space, it's going to take up space and it's going to push all of this left or whatever, the left-sided across the way to the other side. And when that occurs, you're going to see tracheal deviation. And so that's why that's why there's a tracheal shift to the right. Now, jugular venous distension is because what is not pictured here is that the heart sits right here. And not only will you push these structures this way, but you will also push the heart this way. And if the heart is pushed over, it cannot fill and it cannot eject, and that is the cause for jugular venous distension. I know that's a lot of information, and it's all listed on this slide that I presented in the Hughes Clues hypoxemia. But I did want to make sure that you got this because this is a very important concept. If you're still having trouble understanding this, then be sure and email me, and I'll try and explain it again. Again, pause the recording and just try and wrap your brain around it. Last topic, and then we'll be done. So how does ventilator management of the COPD patient? So this is a COPD patient that has known to be a patient with a history of emphysema or chronic bronchitis or asthma. How does their ventilator management, and for that matter, ABG management, differ from that of a patient who does not have COPD? In other words, tell me what, on a good day for a patient diagnosed with COPD, what would their ABG look like? So pause the recording and identify, well, what's their patho? What's the problem that they have on a good day? And what would you expect to see? And hopefully what you identified is that the normal ABG for a COPD patient is that they have CO2 retention, and that is their normal. But because it is a chronic state, that the CO2 is a chronic state, then we know that, you know what, the kidneys will get into the fun and they will hold on or make more bicarbonate. And then the end result of that is that the pH is normal. So what I would say to you is that even though you don't like the CO2 that's elevated, as long as the pH is in the normal range, we consider that the COPD patient is doing okay because they will retain CO2 every day, and as long as the pH is under control, then the acid-base balance is being maintained. It's being kept in the normal range. Now, we do have to look at the PO2, and we know, and the SaO2, and we know again that our course normal, even though you learned in J1 and J2 that 90%, that's bad, well, not in critical care. In fact, I get on my hands and knees and thank the Lord above that my patient has a 90% SAT, because for COPD patients, of course, because they cannot get rid of CO2, well, that means that there's problem getting in O2, and usually their oxygen status is not as good as a non-COPD patient. So again, as long as their oxygen status is 90% or above and that the pH is normal, then we consider that the COPD patient with these ABGs is doing okay. And that's how we would manage, the physician would manage the ventilator. They would manage looking at these criteria, because they're not going to try and get the CO2 down. As long as the pH is okay, then the patient is managed okay, and that's how the physician will manage this patient on a ventilator. I hope this review has been helpful. Please let me know if it hasn't or if you have any questions.